Hi, my name is Minzhe, currently a postdoc fellow in the clinical group at UCL. I will introduce our work about controlling the false positive rate and false negative rate in detecting the prostate cancer in MR images using deep learning techniques. The left figure shows the most newly diagnosed cancer types in the United States in 2021. Prostate cancer alone accounts for 26% of the diagnosis. The right figure shows the most frequent cancer cause of death in the United States in 2021. Prostate cancer alone accounts for 11% of the deaths. To summarize, prostate cancer is one major public health problem for males globally and is one of the leading causes for deaths of males. Multiparametric MRI images have potential to play a part in every stage of prostate cancer patient management, including enabling targeted biopsy for early to medium stage cancer diagnosis, and a screening program for avoiding unnecessary biopsy. However, reading MR images requires highly specialized radiologists, and for those experienced radiologists, it remains a challenging and arguably tedious task. Automated computer-aided prostate cancer detection not only can help significantly reduce the radiologist's time in examining the volumetric MRI images, but also provides highly consistency over human interpreters. To be concise, computer-aided diagnosis system, or a CD system, has the potential to reduce the radiologist's burden and enhance the detection accuracy. The main tasks of a CD system is that, given MR volume of a specific patient, first to determine whether that patient has cancerous lesion, and second to locate the lesions for further biopsy or treatment, and third to classify or grade the lesions. Recent related work formulates the prostate cancer detection as either a semantic segmentation or instance segmentation task. The task of an instance segmentation is actually a combination of an object detection that detects individual objects and the semantic segmentation that classify each picture in 2D or works in 3D into a fixed set of categories. The most classical deep learning algorithms in the above two categories are the UNet and the mask-SN, respectively. In this paper, we would like to answer the following research question in the two-stage object detector. That is, can more desirable false positive rate and false negative rate be controlled by changing their costs during the training process? The overall architecture of our proposed CD system is depicted in this picture. The network utilizes a feature pyramid network backbone on top of a ResNet architecture to generate multi-scale features. The extracted features are shared by the following two modules: a region proposal network module that generates candidate object bounding boxes, and a detection module that performs the bounding box regression, classification, and region of interest mask prediction of the candidates boxes. Note that a slice-level classification branch has been incorporated in the proposed network. The training loss consists of 6 terms, where the first 4 terms are kept the same with those in the original mask-SN paper. The differences or improvements of the proposed algorithm include the follows. The classification loss at the region of interest level is modified to be a weighted cross-entropy. In addition, one slice-level weighted cross-entropy classification loss is added to the overall training loss. More specifically, the lesion-level cost-sensitive classification loss is defined in this formula. In this formulation, PR star is 1 if the ith region proposal is positive. Otherwise, PR star is 0. With larger value of alpha than beta, the network emphasizes more on the regions with positive labels, and thus punishes the lesion-level false negatives. On the other hand, with larger value of beta than alpha, the network emphasizes more on the regions with negative labels, and thus punishes the lesion-level false positives. This term is the slice-level cost-sensitive classification loss defined as the weighted cross-entropy. In this formulation, P/* indicates that there is at least one cancerous region in the interested slice. P/ is the largest predicted probability of one detected region being cancerous. Likewise, the case at the lesion level, with larger value of alpha than beta, the network penalizes false negatives more heavily at the slice level. With larger value of beta than alpha, the network penalizes more the false positives at the slice level. The dataset consists of 290 clinical cancer patients. The ratio of training, validation, and test sets are said to be 8:1:1. The ground truth labels are acquired by the experienced radiologists according to the PARAS, and the lesions with PARAS score larger than 3 are regarded as clinically significant. The neighboring slices are included from the 2.5-dimension input. In the training process, the network is trained for 100 epochs, with the initial learning rate being 0.001. Random affine transformations were applied for augmenting data during the training process. The evaluation metrics are defined at both the slice level and the lesion level. For example, at the slice level, one slice with ground truth lesion and with at least one predicted lesion is considered and counted as a true positive slice. At the lesion level, for example, a lesion is regarded as a true positive if one ground truth lesion has an intersection of union greater than or equal to 0.2 between that ground truth bounding box and any predicted bounding box. At the lesion level, one difference is that there is no definition of a true negative lesion. This page shows some quantitative results. Table 1 shows the results where the weights at the lesion level are adjusted. Table 2 shows the results where the slice level classification loss is added and the weights are adjusted. Table 3 shows the results where the cost-sensitive classification loss at both the lesion level and slice level are incorporated into the overall training loss. Alpha indicates the value of alpha lesion and alpha slice. Beta indicates the value of beta lesion and beta slice at the same time. The false positives and false negatives can be reduced by choosing the suitable weighting schemes, and the incorporation of the slice level classification loss can reduce the false negatives at both the lesion level and the slice level. The first 3 columns show results with different weighting schemes during training. The 2 rows denote results with 2 classification scores threshold at the inference stage. By comparing figure C and figure A and B, we can see that false negatives have been reduced. By comparing figure G and figure E and F, we can see that the false negatives have been reduced. By comparing G and C, the false positives have been reduced by further adjusting the threshold at the inference stage. This figure shows the weighting scheme's ability to reduce the lesion level false positives. By comparing C and A and B, we can see that false positives have been reduced. By comparing G and E and F, we can see that false positives have been reduced. This can also be seen by comparing G and C, by comparing F and B respectively. The slice level false negatives are validated to have been reduced with the slice level classification loss incorporated. For example, by comparing B and A, the slice level false negatives was reduced with the sacrifice of one more lesion level false positive. By comparing J and I, both lesion level and slice level false negatives were reduced with the sacrifice of one more lesion level false positives. To conclude, in this study we explore the feasibility of controlling the false positives and false negatives at the lesion or slice level during training, together with an in-depth analysis of the advantages and disadvantages. Thank you so much for watching. I'd like to take any questions. Thanks.